السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بالجميع. إدارة الشؤون الأكاديمية وتدريب صحة الطائف ترحب بالجميع. دورتنا اليوم بالتعاون مع مجمع الملك فيصل ممثل بقسم المختبر. طبعا دورتنا اليوم بقيادة الدكتورة إيمان مصطفى كشك، طبيبة أخصائية تشريح نسيجي، ماجستير ودكتوراه في علم الأمراض جامعة القاهرة. طبعا موضوعنا اليوم حيكون عن Dermatopathological emergencies, case study and review of literature. اتفضل دكتورة إيمان، المايك معاك، اعمل الشير سكرين.
السلام عليكم، ازي حضراتكم جميعا؟ يا رب تكونوا بخير ان شاء الله. نبدأ حالا. استاذ طارق انا كده
اتفضل.
تمام؟
ايه تمام.
Okay. Hello everyone. This is Iman Mustafa. I'm a histopathology specialist at King Faisal Medical Complex, and I'm very excited about being with you today. And I hope this is my first time. I hope this is not the last. And today's lecture, I'm very excited about it because we are going to talk about dermatopathologic emergencies. We have a case that came to our department at the complex, histopathology department. And I'll take the opportunity to discuss other emergency histopathologic dermatopathologic cases because most of the histopathologists are actually excited about the malignant skin diseases like the malignant melanoma, squamous cell carcinoma, and actually none of these cases is a tumor. The mighty skin tumors are not there, no melanomas, no Merkel's, no squamous cell carcinomas. They are just all diseases, which are all emergencies, and every pathologist have to know them by heart because missing one of these diseases can cost the patient his life. Okay, so let's start with our case at first. Our case that we had a 30-year-old male that came to our hospital with numerous hemorrhagic bullous eruptions that started on the trunk extremities, and then they spread centrifugally to involve the face, the mucous membranes, and the trunk. He mentioned history of drug intake, and the symptoms were of 1 week duration. And these are the pictures of our patient. Numerous hemorrhagic ulcers, and there were vesicles and bullae also. They start on the trunk, as you can see, and they spread peripherally to the extremities with hemorrhagic, ugly-looking ulcers. Okay, here also it involves, as you can see, more than 30% of the body surface area. Okay, here also. Okay, with the closer view, if you look at his feet, you can see remnants of vesicles. Okay. Okay, gross pathology that the lesion was just a small punch, 0.5 multiply 0.5 centimeter. Of course, it was totally embedded. And when we look at the histopathology, we see, I want to explain, to stay with the histopathology for a while because it's my specialty, and also the dermatopathologists and general pathologists and dermatologists would like to talk about this. As we can see, there is a subepidermal blister here. As you can see, here is the mouse, there is the skin, there is subepidermal blister with extravasation of serum and little inflammatory cells. They are not much. And if you look at the side of the lesion, the keratin is orthokeratotic, basket weave keratin. That means that the lesion is acute. It's not a chronic disease that stays for months. If so, it would show compact orthokeratosis or parakeratosis, but the lesion shows just orthokeratosis. That means it's of acute onset. Okay, on closer view, you can see here the skin is more or less unremarkable. On the side, on the actual lesion, the skin looks that it lost some of its basophilic nuclei. Actually, it becomes necrotic. Okay, and this is the blister that is filled with serum with some inflammatory cells. Okay, and then on the higher power also, it's very clear that the epidermis is necrotic with the underlying also extravasated serum and inflammatory cells. Another view also. Here is also, it's very obvious here that the epidermis is necrotic and the orthokeratin is here. And also, as we can see, there are satellite cell necrosis. That means that the necrotic keratinocytes are surrounded by few lymphocytes. Okay, this is also a characteristic for this disease entity. We suspected a diagnosis, which was usually if we have a fluorescence, we do immunofluorescence for IgM and C3, but fortunately we have these as immunohistochemical markers. And the disease showed positive immunohistochemical staining for C3 at the dermoepidermal junction in the nearby normal skin and also at the site of the blister, as you can see here. Closer view the same. This is the blister, and there is positivity for C3, basal location, more or less. Another view for C3, and this is IgM, the same pattern for the C3 basal deposition, okay? And also at the dermoepidermal junction at the top of the blister, okay? Another picture for IgM. So using the constellation of the clinical picture and the histological as well as the immunohistochemical findings, these features are all suggestive of Stevens-Johnson syndrome toxic epidermal necrolysis spectrum. And I'll explain to you now why this is called a spectrum, not a specific entity, because it depends on the percent of the body surface involvement. So it's not a one-man show for the pathologist to decide. It depends on the clinical factors. And also here, it's very important, the correlation between the dermatologist and the histopathologist. Okay, this is the dermatology is one of the branches that there must be a close correlation between the clinical and the pathological. Otherwise, will not reach a precise diagnosis. So Stevens-Johnson syndrome, toxic epidermal necrolysis, and the mildest form of them is the erythema multiforme. They are all considered as a continuum. The patient usually present with, as you see, bullous eruptions, and I'll explain in a minute how the disease evolves, and also the patient shows some constitutional symptoms. And it usually, as mentioned from the clinician, it starts on the trunk and spreads centrifugally. And when it involves less than 10% of the body surface area, it's called erythema multiforme. More than 30%, it's toxic epidermal necrolysis. And when it's in between, it's the spectrum of Stevens-Johnson toxic epidermal necrolysis spectrum. And as you can see here in the pictures, the mucosal involvement is usually present in the severe cases with high mortality rate in cases of the toxic epidermal necrolysis. And usually the patient presents with the history of drug intake, as in our patient, he presents with history of intake of some drugs, and usually the most common culprits are the non-steroidals, the sulfonamides, and antiretroviral drugs. And the differentiation, as I said, it depends on the clinical picture between and the correlation between the dermatology and the pathology department. Okay. This is another picture for the grave, the aggressive, the fatal toxic epidermal necrolysis. Okay. And I'll explain why these diseases shouldn't be missed. If you miss a diagnosis of a melanoma or merkel cell carcinoma, these diseases, the patient is not going to die within a day or two. But if you miss these diseases, if not appropriately diagnosed, the patient here should be treated in a burn unit with fluid replacement and prophylactic antibiotics to protect against sepsis, which is the most common cause of death, actually. If the pathologist missed the diagnosis of these entities, one of them is toxic epidermal necrolysis, of course, the patient might die within a day or two. So not all the interesting or the important diseases in pathology are just tumors, okay? So the pathologically, as we saw, this is our disease is the full-blown picture of toxic epidermal necrolysis, but I will explain how the disease evolves. First, the erythema multiforme, the mildest form of the disease, it begins as you all know, it's a prototypic for vacuolar interface change, and I'll show you pictures. Interface dermatitis with vacuolar degeneration at the dermoepidermal junction, necrotic keratinocytes, and the satellite cell necrosis. Then as the disease progresses, there starts to be the blistering, okay? And then with more progression, the epidermis becomes necrotic with more extravasation of edema fluid, many inflammatory cells. And as I say, the positivity for C3 and IgM in the superficial dermal vessels, as well as the dermoepidermal junction, okay? And it's very important also to know from the clinician from where the biopsy is taken, because if you have a case of Stevens-Johnson syndrome or toxic epidermal necrolysis and the clinician took the biopsy from the edge of the lesion, it can look very similar to the erythema multiforme, the minor form of the disease, where it shows just the interface changes with the vacuolar degeneration of the basal keratinocytes. But if she says that we have ulcers, hemorrhagic and blistering, and the picture we have in our patient, so it will put the findings into a reliable picture. Okay. And here is how the disease starts. This is also orthokeratotic. I want to explain for everybody how the pathology is interpreted. Okay, this is the keratin is orthokeratotic basket weave keratin, which means that the process is acute. It's just of a few days onset. And here is the minimal inflammatory infiltration, superficial perivascular dermal lymphocytes, as well as vacuolar degeneration of the basal keratinocytes. And the closer look here, you can see scattered necrotic keratinocytes here and there with satellite cell necrosis. That means the necrotic keratinocytes are surrounded by few lymphocytes. This is characteristic of this entity. However, it can be seen with other diseases, but it's very common in the erythema multiforme, the earliest form of the disease. Here is another view. Here starts when the disease progresses more. There starts the blistering at the base of the epidermis between the dermo-epidermal junction and the basal layer of the epidermis. And here is the full-blown blister where the epidermis is separated from the underlying dermis, and the epidermis doesn't look very happy. It lost the basophilic nuclei. That means that it starts the process of necrosis. Okay. Well, the role of the pathologist here is to differentiate between toxic epidermal necrolysis and other mimics, which can be of grave importance for the patient because missing the diagnosis will result in inappropriate treatment. Okay, the most important differential is that staphylococcal scalded skin syndrome can look very similar clinically to our disease, but histologically it's very, very distinct. Where the staphylococcal scalded skin syndrome, the blister is just below the stratum corneum or in the granular cell layer, whereas in the toxic epidermal necrolysis, it is subepidermal blister with full thickness epidermal necrosis. And sometimes here there is a point I want to stress on: the frozen sections can be used to make this differential. Most of the pathologists use, the frozen sections for diagnosis and of malignant or tumors and their margins. But here also the frozen can play a very important role. And somebody might ask why we use the frozen section, why we do not just send the case for permanent sections, the paraffin sections. The answer to this question is that this disease is an emergency. The disease is an emergency. So it cannot wait until we have the 7 days turnaround time of the turnaround time of the 5 days turnaround time of the pathology lab. It has to be diagnosed immediately. Also the burn, the frostbite, okay, can have similar picture. Acute graft versus host disease following transplantation, especially bone marrow, and also herpes simplex, herpes zoster. And that's why the clinical history here is very important. Here, the pathology cannot be working alone. We have to, the burn can look very similar, but it would be easy. The patient will present with the clinical history that he had a burn, okay? The same for frostbite. For graft versus host disease, the patient will mention a history of bone marrow transplantation, okay? And for the viruses, we will see the viral cytopathic effects, which are very characteristic histology, okay? That's why I'm here stressing that the clinical history is of grave importance here. Okay. The treatment of our patient, as I mentioned, that more than 30% of the body surface is involved, it's dealt with as a third-degree burn, and he has to be admitted to the burn unit with fluid and electrolyte replacement, care for the wounds, and cyclosporin to protect against secondary infection. And this disease, as I said in the beginning, it is an emergency with mortality rate ranging from 10 to 25%, and the sepsis is considered the most common cause of death. Okay, I hope everybody is following. Okay, should I complete?
Okay.
Then we will move to the other emergency dermatopathologic conditions, the other cases, the other entities that mustn't be missed. Okay. Okay. As we said, the staphylococcal scald skin syndrome, we will talk about it in more details, okay? The other entity is necrotizing fasciitis, pyoderma gangrenosum then, and finally, the cases of acute ischemia. Acute ischemia can be missed histologically because it causes very subtle histological changes, which can be easily missed, but the consequences for the patient will be grave, okay? Let's start with the staphylococcal scald skin syndrome. This disease is caused by Staph aureus, okay? But an important point here, it's not caused by the bacterium itself. It's caused by the toxins produced by the bacteria, okay? That target the desmoglein. The desmoglein is a glycoprotein that holds the cells in the epidermis together. That's when the epidermal lysin produced by Staph aureus targets the desmoglein, the blistering happens and the epidermal sloughing, skin necrosis, and wide areas of skin sloughing. Because it's caused by Staph aureus, so the neonates and children less than 5 years of age are the most commonly affected, and also the immunosuppressed patients. And large sheets of the epidermis separate and exfoliate, okay? And of course, because of its bacterial infection, the patient can have constitutional symptoms like fever, symptoms of upper respiratory tract infection, symptoms that there is a bacterium somewhere, okay? The grossly, the lesion cannot be very much by the gross picture distinguished from the other blistering disorders, especially toxic epidermal necrolysis. However, we depend very much on the clinical picture. Like the patient is young, it has history, he has history of upper respiratory tract infection, skin infection, okay? But the gross picture, let's talk about the gross picture. The bulla are usually flaccid, the blisters are usually flaccid, and they rupture almost immediately. Once they are formed, it will rupture almost immediately. And the clinician will mention this. And also it has positive Nikolsky sign. This sign that dermatologists know better than us, that when you press on the blister from one side, it expands to the adjacent non-blistered skin, which is very helpful in this disease, okay? And there are very large areas of desquamation, skin separation, necrosis, and it's usually involved with, the usually involved areas are usually the axilla, the groin, and around the body orifices, and the mucosal membranes are typically spared, which is a very important distinguishing point from the toxic epidermal necrolysis, okay? There is a picture for the staphylococcal scald skin syndrome. This is an infant with, as you can see, wide areas of the skin desquamation and separation. And here is the bulla that ruptured immediately. It's superficial because, as we are going to talk about the microscopic picture, the blister is just below the granular layer or below the corneal layer. And there is minimal, if any, inflammatory infiltrate that can look very subtle. And sometimes when, because of the blistering, the corneal layer is lost or the granular layer is lost, the skin will look as almost normal. But when you look closer, you will not find the cornified layer or the granular layer, and there is the pathology. And of course, the gram stain and direct immunofluorescence will come out negative. The staph is not present in the lesion. And this is an important point because if a staph is present in the lesion, okay, there will be subcorneal neutrophilic infiltrate, and I'll show you pictures. And also the gram stains will be positive, and the diagnosis in this case will be bullous impetigo and not staphylococcal scald skin syndrome. I know for some that the dermatologic expressions are a bit complicated, but I hope you all enjoy the session. Okay, the blister is in the uppermost part of the epidermis, as I said. As we said that if it's caused by the staph itself, numerous inflammatory cells, and the gram stain would be, and the cultures of course will come out positive, okay? Here's a picture. As you can see, there is the site of the blister. It's subcorneal or in the granular layer, not here as in our case, toxic epidermal necrolysis. And if you can see here, there's minimal inflammatory cell infiltrate in the superficial dermis. It can look almost normal. And here you can say that this biopsy is completely normal, but not. If you look, there is no cornified layer, no granular cell layer in this biopsy. So in a child, it's diagnostic of staphylococcal scald skin syndrome. The differential, as I've just said, the bullous impetigo. Look here, there is also the same site of the blister, immediately subcorneal, with numerous inflammatory cells, and the gram stain here was positive for the staph organisms. Okay, it's caused by Staph aureus This is the most important differential. Also, the pemphigus foliaceus, it's a subtype of the pemphigus family of diseases where the blister is also at the same level. Here, you know, histologically, the differential will be very difficult, but immunofluorescence will show that characteristic net-like pattern for IgG and C3 in the all immunoglobulin, on the all pemphigus family of diseases except the IgA pemphigus. So in our disease, the staphylococcal skull skin syndrome, it will be negative for the immunofluorescence. This is characteristic. And for the pemphigus, it will show the fishnet pattern for IgG and C3. And we explained before the Stevens-Johnson syndrome, toxic epidermal necrolysis. Okay. Okay. The outcome and the treatment, this child has to be treated to treat the infection with staph, so he has to take antibiotics. And most of the cases, the fatal outcomes in this disease are due to the secondary bacterial infections that happen because, you know, you lost the superficial, most protected part of the skin, the corneal layer. So it's easy for bacteria to access your body. Okay. The outcome is even worse in adults because they will be more immunosuppressed if they got that disease, and they have increased rate of sepsis, and the mortality rate exceeds 50%. Okay, the next entity is called the necrotizing fasciitis. Its other name is flesh-eating disease. So from its name, it looks like very aggressive and very grave disease. And it's necrotizing infectious process with non-specific histological picture that involves the skin and the deep soft tissues. It's usually fulminant, rapidly progressive, with extensive necrosis of the deep subcutaneous fascial tissues and even the muscles, okay, as from its name. It differs from the other entities of, you know, neutrophilic dermatosis and cellulitis by its deep location, okay? So nothing specific histologically, just necrosis, numerous inflammatory cell infiltrates, maybe vascular thrombosis, okay? But in deep locations, in the deep soft tissues, the subcutaneous, the fascia, and the muscles, okay? And it's also caused by bacteria, mostly Strep, okay, Streptococci, and MRSA, Pseudomonas, but usually it's polymicrobial, okay? The mortality rate is higher if the patient is immunocompromised, like diabetics, cancer patients, organ transplant patients, and the treatment here is aggressive with aggressive antibiotic therapy and aggressive surgical debridement. And here comes another important role for the frozen section other than malignant diseases or diagnosing tumors. Here, because the surgeon needs to debride this disease very extensively, he might send you the surgical margin to say if it's viable or not, to be sure that the margins of the disease do not show the necrosis or the extensive inflammatory cells that are present in the disease itself. He must have a clean margin so the patient will not suffer from losing a limb or something, or pay his life from this grave infection. Okay. So it has classic also clinical picture. That's why, again, there should be a close correlation between the clinicians and the pathologists. Usually the patient has previous surgical procedure. Then the necrotizing fasciitis starts as first erythema and then bullous and emphysematous lesion. And then after a while, the lesion becomes purple, cyanotic, with following skin and soft tissue necrosis and skin sloughing. As we can see here, this patient, okay, these patients were immunosuppressed, and as you see here, there is cyanosis of the limb, okay, that looks ugly, with blistering and hemorrhage, and later on there happened that necrosis of the skin and skin sloughing. The deep tissues also are involved by necrosis and severe inflammation, and the surgeon has to do extensive debridement with wide coverage with antibiotics to ensure that the patient has no remnants of this grave infection, to not to lose his limb. But this is an aggressive disease, of course, as it looks like really emergency. Okay. So as we just described, the necrosis and the inflammation involve the fascia and the subcutaneous fat and the muscles. As you can see here, this is the subcutaneous fat and surrounded by necrosis and extensive inflammatory cells. And here's also the vessel wall is also involved. With involvement of the vessel wall, subsequent thrombosis can happen, which will aggravate the process of necrosis and make the situation worse. Of course, if we did cultures and gram stain, it will come out positive. And this is also an important role for the correlation between the pathologists and microbiologists. For we will say, okay, it's a picture compatible with necrotizing fasciitis, but we cannot specify the organism. So we have to refer to the microbiology for the proper subtyping, okay, and the proper selection of the antibiotics. And the cultures, it will come out positive, of course. They will tell us what is the bacteria causing this disease. And another picture, this is a low power view to make the things more, wide scope. Here is the epidermis, doesn't look so remarkable. The superficial papillary dermis, also the dermis doesn't look very, very much of concern. And then the subcutaneous fat, as you can see, the inflammation extends deep down the subcutaneous fat, and also involves the fascia and also the muscles. But the section will not bring all from the epidermis to the muscle. But here, the important thing that it starts very deeply, and then later on the skin will be sloughed and necrotic. And here there is a perivascular inflammation, thrombosis, and necrosis involving the subcutaneous fat, as you can see. Of course, there are, as I said, it's not specific histologically by any means. So we'll have differentials. The first is cellulitis. The second, pyoderma gangrenosum, and autolytic tissues due to secondary bacterial overgrowth. All of these conditions, the inflammatory, infiltrate, necrosis, are dermis-centered. They do not involve the deep subcutaneous tissues, they do not involve the fascia, do not involve the muscles, okay? So if it's not treated appropriately, of course, it would be fatal, and this is, again, another emergency disease that shouldn't be missed, okay? I will not just say acute inflammation with abscess formation, next case, no. But that way, the patient will not be properly treated with wide surgical debridement and extensive coverage of antibiotics. Surgical treatment is a very important part in this disease, okay? Let's talk about the other entity. As I told you, the frozen section here is very important. And there is a variant of the necrotizing fasciitis called Fournier gangrene, which involves the genitalia and abdominal areas, okay? It's the same disease, but with a different name, okay? The pyoderma gangrenosum, this is a very interesting entity, by the way, and it should be diagnosed by the dermatologist, not the surgeon, because if it's diagnosed by the surgeon and not diagnosed, he will see an ulcer and he will bring a biopsy for the pathologist. And by all means, also, it's not specific pathologically, okay, just inflammation and ulceration. And when you say acute inflammation, full stop, abscess formation, the surgeon might go and make wide debridement for the ulcer, which is usually fatal in this case. This case should avoid trauma and surgical management. See how important the correlation is to correlate clinically and pathologically, so the patient will get the most benefit. So this disease is also an ulcerative idiopathic disorder, results in painful ulcers. They usually appear on the trunk and extremities, okay? And they have common association with inflammatory bowel disease. And this also has to be mentioned in the clinician's report. Other less common associations like the myeloid leukemia and arthritis, and the lesion shows that the phenomena of pathogy, that the lesion flares and progresses with the surgical trauma, okay? Any trauma, by the way, but surgical because it's real grave trauma. So the variants, the classic ulcer, other less common variants, that the superficial pustules, bullous forms, and granulomas. It has very characteristic appearance grossly. That's why I'm saying that it should be diagnosed by the dermatologist. That the ulcer, it has large necrotic infected base with a violaceous border that is surrounded by erythema. And with healing, it has very characteristic appearance that it gives a cribriform or crisscross pattern upon healing. And I show you pictures. Okay, this is how the lesion starts. It looks like purplish violaceous lesion. And then it starts the ulceration with deep infected ulcer surrounded by violaceous border. And here it's more beautiful that the lesion is deep, violaceous border, and surrounded by erythema. This is typical. And the dermatologist knows how to diagnose it. And he will write in the report that it's an ulcerative disease involving the extremity, likely pyoderma gangrenosum, or he will write differentials like inflammatory ulcer, stasis dermatitis, stasis ulcer, pyoderma gangrenosum, because in all means it's not specific the histological picture. Here is also another picture for the disease, and here is the characteristic appearance when the lesion starts healing. It looks like cribriform, crisscross appearance when it starts healing. Okay, this is very specific for this disease entity, the pyoderma gangrenosum. And microscopically, as I just said, it's not specific. The lesion presents with, it starts with subcorneal pustulation, and then it shows nodular and diffuse neutrophilic infiltrates in the dermis and the subcutaneous tissue. This is the most typical, but as I said, this is also not a specific. For me, the specific picture for the pyoderma gangrenosum, that the neutrophils undermine the edge of the ulcer, okay, especially at the epidermal junction at the edge of the ulcer, where the neutrophils, they encroach on the dermo-epidermal junction at the lower border of the epidermis, especially at the edges, with marked pseudoepitheliomatous hyperplasia of the overlying epidermis. Giant cells may be present, thrombosis, necrosis of the dermis. Okay, these also happen with this disease entity. So the clinician sends the cases of suspected pyoderma gangrenosum for the pathologist, just to be sure. This is not an infectious etiology, not caused by bacterium, let's say, that it's not a malignant ulcer if the patient is old, just like this. And then he'll write the report that the patient has an inflammatory lesion with ulceration that undermines the adjacent epidermis. Picture is compatible with the clinical diagnosis of pyoderma gangrenosum. Okay, so this is a picture for the microscopic picture, as I just said. Look here, the neutrophilic infiltration is reaching the base of the ulcer, actually undermines the epidermis with abscess formation. Marked pseudoepitheliomatous hyperplasia is seen here that can be diagnosed as a squamous cell carcinoma by the unwary. Also, giant cells are present with some dermal necrosis. Here also another view, as you see here, the ulcer with numerous inflammatory cells in the dermis, and this is the pseudoepitheliomatous hyperplasia of the epidermis. Pseudoepitheliomatous hyperplasia means that the epidermis is proliferating very much, that it dips very deep into the dermis. It can look like malignant for the juniors, let's say. And here is another view. Also look here, the inflammatory cells are undermining the edge of the epidermis with some spongitic changes, edematous changes in the adjacent epidermis. Of course, as I said, that our role as pathologists is to exclude infectious etiologies. So we have to do fungal and bacterial stains like the PAS, GMS for fungi, and Zell-Nelson, Gram stains, Grokut. We also have to refer the case for culture to exclude infectious etiologies, which is by far most common than the pyoderma gangrenosum. And it's very important to treat the patient with antibiotics to avoid second bacterial infection, wound care, and the most important is to avoid trauma, avoid surgical debridement, because this is of the pathogen phenomenon that the lesion is going to progress and be more fatal if the surgeon decided to take this ulcer out. Okay. The differential diagnosis here. Other causes of marked infiltration of the dermis by neutrophils with undermining of the dermal junction with ulceration, okay, especially the infectious diseases. As we say, we have to do the special stains for the bacteria and fungi, and to refer the patient for the culture, take a swab and culture it from the lesion to exclude bacterial infections and things like this. And also sweet syndrome. Sweet syndrome, it's prototypical neutrophilic dermatosis, but it has a characteristic picture. As you see here, there are tons, this is sweet syndrome, tons of papillary dermal neutrophilic infiltration with the papillary dermal edema and no ulcers. Sweet syndrome doesn't have ulceration. Dermal inflammatory cell infiltrate, papillary dermal edema, and no ulcers. So this is the last entity to talk about the causes, the emergency causes due to acute ischemia. And the causes of acute ischemia are divided into three categories. I'll try to talk about them quickly, which are the angioinvasive fungal infections, okay, and calciphylaxis and thrombotic vasculopathy. And I will start with the angioinvasive fungal infection. The invasive fungal infections and the angioinvasive ones that invade vessel walls and cause thrombosis, necrosis, are typically diseases of immunocompromised patients that are diabetics, malignant patients with malignant diseases, or organ transplant recipients. A lot of fungi are responsible for this. The most common known examples that Aspergillus, Mucor, Histoplasma, and others, of course. The important thing here that the dermatopathologists or pathologists are the first to see the disease. It comes to you as a skin lesion, and you are the first one to encounter the, oh wow, there is invasive fungal infection here. And if you missed it, the patient will not only lose a limb or something. The fungus will disseminate and will have an invasive systemic fungal infection that can cost the patient his life. So again, this is another emergency disease that has to be well diagnosed and recognized, and to start immediately the proper antifungal treatment, so to save the patient's life. So invasion of the vessel wall by the responsible fungi will result in vascular wall damage, subsequent thrombosis, and tissue necrosis with catastrophic tissue ischemia and infarction. When we suspect as pathologists fungal infection, we usually do fungal stains like the GMS, PS, and Brocut, okay? And I'll tell you something, as a pathologist, never try to subclassify the species of the fungus based on the histological picture. It's not our duty. You have to refer the case for microbiological culture to specify the species of the fungus appropriately in order not to give the wrong antifungal drug. So resistant antifungal strains will emerge. So we just say that it's angioinvasive fungal infection, and the case is for microbiological correlation for proper subtyping of the species. This is very important. Do not, as pathologists, do not be pushed by the clinician to give you to try to push you to give you to give him the subtype of the fungus present in your specimen. So here, as you can see, this is a vessel wall surrounded and invaded by numerous spores and hyphae of fungus infection with intraluminal thrombosis. Okay, and this is Brocut stain. It's a very nice fungal stain that highlights that you have a fungus, and you stop here and to refer the case for the microbiology, as I say. Okay, and the other entity of the acute ischemic causes of emergency dermatopathology, the thrombotic vasculopathy, which could be due to primary vasculitis or secondary causes. The secondary causes are usually due to DIC, disseminated intravascular coagulation, hemolytic uremic syndrome, cryoglobulinemia, and others. The dermal vessels are usually obliterated by hyaline deposits, plus or minus inflammatory cells, which are more common, of course, in the primary causes. The primary vasculitis results in fibrinoid necrosis of the vessel wall, leukocyte and vascular thrombosis, of course. And in the vasculitis, the arterioles and postcapillary venules are the most commonly involved. The vascular insufficiency causes progressive tissue ischemia and infarction. And the secondary deposits that I say due to other causes that might insult the vessel wall, it has characteristic appearance, very minimal inflammation, peripheral fibroid material at the vessel wall, and focal thrombosis. Okay. And as you see, it looks that the peripheral, the distal extremities suffer from the vascular insults with cyanosis, starting necrosis, as you can see here and here. And of course, when there is vascular compromise, secondary bacterial infection can supervene. And here is a picture for what I'm saying, that here is, these are the vessels here in the dermis. You look in the low power, I'll show you high power. There is intraluminal hyaline thrombi with fibrinoid necrosis in the vessel wall. The vessel walls are not very good, are not very healthy. They show fibrinoid material deposited, and also here they have wide areas of dermal necrosis and also epidermal necrosis. This closer view, the hyaline thrombi present inside the vessel walls with focal fibrinoid necrosis. Here it's more obvious. The fibrinoid necrosis of the vessel wall is very obvious. As you can see, these changes might look subtle with the eyeballing method of examining cases microscopically. So you have to look carefully at the cases because these are very subtle. And if you miss them, the patient can lose a limb and even may lose his life. Okay, the patient, if is diagnosed with melanoma, okay, the patient is not going to die within a couple of days. He will have an excision, we will have treatment. But these cases, the patient don't have a lot of time, okay? So the last entity I'm talking about today is the calciphylaxis, okay? The other name is the calcifying panniculitis, okay? It differs from the dystrophic calcification. Dystrophic calcification is the calcification that is deposited in the interstitial tissues, but the calciphylaxis is the deposition of calcium at the vessel walls, okay? It can look like, you know, just calcification if you're not very careful. And also it will have serious consequences. It usually happens in patients who are with renal failure and they have got hyperparathyroidism secondary to this. With renal failure and hyperpara, they got elevated calcium and phosphorus levels that exceed the body's ability to clear them out, and the calcium started to deposit in the skin, in the vessels of the skin, the subcutaneous fat, less often the muscles, and they are usually on the lower extremities and they're bilateral, symmetrical, and tender. Okay, they are deposited in the intima media of the vessels, okay, large and small vessels. Might be surrounded by fibroblastic proliferation, and with vascular compromise and thrombosis, there might happen hemorrhage and necrosis of the subcutaneous fat. As you can see here, this might look very subtle histologically. Okay, scattered areas of calcification, and they can be even more subtle than this. Deposition of calcium, okay, in the vessel wall here and there. Also another picture. You see, this is very, very important. This vessel is going to be occluded and will affect the vascular supply of the limb. So it has to be recognized immediately. Okay, another case, okay, where the calcium is deposited in the vessel wall, and the patient will suffer from catastrophic tissue ischemia, subsequent infarction and necrosis. Okay, and the treatment, of course, is to treat the renal failure and remove the autonomous parathyroid glands, of course, to give oxygen and to maintain the vascular supply to the limb, and to give corticosteroids. Well, I believe this is my last slide, and what I want to say at the end, the take-home message that is the dermatopathology is not a one-man show. We have also always to correlate with the dermatologist and with the microbiology to decide the appropriate treatment of the patient, correlate with the clinical picture, as in many cases, we are just confirming the differential or the diagnosis of the clinician. Also, not every case in pathology, interesting case in pathology or important case in pathology is a tumor, is a malignant tumor. Other disease entities can be more serious and can cost the patient his life if not properly diagnosed. Okay, and thank you so much for your attention. I hope you enjoyed the session, and I enjoyed being with you today and hope to repeat it soon. Thank you so much.
Thank you very much, دكتورة. صراحة محاضرة جميلة جدا، ممتعة. الله يعطيك الصحة والعافية، بارك الله فيك. أستاذة خديجة.
أيوة، السلام عليكم.
عليكم السلام.
تفضلي ديري الحوار، الله يبارك.
طيب، أول شيء في البداية أقول الحمد لله وصلى الله وسلم على رسول الله وعلى آله وصحبه ومن اهتدى بهداه. أشكر الله على ما من به من هذا اللقاء الجميل والرائع. لقاء اليوم كان عرض لحالة وصلت مختبر مستشفى الملك فيصل في قسم الأنسجة، وقام بتشخيصها، يعني تشخيص هذه الحالة الدكتورة إيمان مصطفى كش. الله يعطيك العافية دكتورة.
الله يعطيك العافية.
طيب نبدأ في الكويستشن. في سؤال: if we do tissue culture and indifty of fungal or bacteria element with a need antibiotic, what will be the role of histopaths in this situation?
In which case?
In diagnosis.
Okay. As I say, certain diseases we talked about, they have a role, they have bacterial or fungal etiology. In these cases, the culture and the specialist stains will help very much. Okay, we just say we exclude or prove the presence of infectious etiology and exclude the presence of a malignant disease. Okay, and then it becomes the role of the microbiologist by this time, and to start the proper treatment with antibiotics. I don't know if this answers your question. Other diseases, we said, like the pyoderma gangrenosum, it doesn't have an infectious etiology. Okay, so we just prove that the diagnosis of the clinician and also staphylococcal skull skin syndrome, we prove the diagnosis of the clinician and we say it's not associated with infectious etiology. So it's not going to be treated, the disease not going to be treated with antibiotics.
Yes.
مش عارفة يا أستاذة خديجة إذا كان ده هو ده قصد السائل من السؤال.
هو عبد الله عسيري، أستاذ عبد الله هو اللي سائل السؤال.
أيوة.
إن شاء الله يكون الإجابة وصلت. في سؤال ثاني دكتورة question. What are the most common skin disease? What are diagnosed in the laboratory department?
Yes, in our histopathology department, the most common diseases which come to us are benign diseases like the nevi, the different types of nevi. Sometimes we have malignant melanomas, which are not very common. We have blistering and inflammatory dermatosis, a good number of cases of inflammatory dermatopathologic lesions. Also lymphoid infiltration and lymphoid disorders of the skin like the mycosis fungoides and anaplastic large-cell lymphoma of the skin. This is not very common, but the most common diseases are the nevi, the squamous cell carcinomas, basal cell carcinomas, inflammatory dermatosis, okay, with all its types. These are the most common diseases that we encounter in the histopathology department in the skin. And also the pinoneedle sinuses and infectious etiologies, of course, and the tumors of the sweat glands. These are all common.
Question, what type of the machine used in the department for histopath?
What do you mean machine? Your processing machine or immuno?
Immuno machine.
Immuno machine?
Yeah.
We have Leica and we have Ventana. We use both. This would be ده كده يبقى إعلان يا أستاذة خديجة.
لا اللي في الجسم اللي مستخدم عندنا في المختبر.
إحنا بنستخدم لايكا أكتر.
ما في أسئلة. أستاذ طارق. أستاذ طارق.
أيوة معكم، الله يعطيكم الصحة والعافية، بارك الله فيك.
عندك سؤال؟
لا والله الصراحة كل الشرائح اللي عرضها الدكتورة كانت